Okay, so this installment is going to go over changes in the pregnant body and cultural concerns. So we'll start with reproductive system since that's the biggest change, right? So some really significant changes occur in the uterus during pregnancy. Before the pregnancy, the uterus weighs like 2.5 ounces, about 70 grams. It has a fluid capacity of about 10 milliliters. So if you think about it, that's like a saline flush, right? Not a lot. But by the time they break to the end of pregnancy, the uterus can weigh 2.25 to 2.5 pounds and can have the capacity to hold up to 5,000 milliliters. So that is 5-liter bags or 10 half-liter bags. That's a lot, right? Pretty cool. So let's move on to the respiratory system. So the respiratory system, there's a lot of stresses that happen during pregnancy. The diaphragm is actually pushed up to the thoracic cavity by the uterus, and this causes about 1.5 inches displacement of the diaphragm. The rib margins will actually kind of flare outward to try to compensate for this, which is going to it's going to increase the lower thoracic diameter and the total circumference by as much as 2.5 inches. So that diameter there is going to get bigger. The maternal oxygen demand is going to increase, and the respiratory physiology actually changes to accommodate this. You've got progesterone, and what this is going to do is it's going to decrease the medullary respiratory center threshold for carbon dioxide, which is going to cause the bronchi to dilate, and it's going to help regulate the mucus production. Okay. Overall, decrease in airway resistance is going to occur, and oxygen consumption is actually going to go up by about 20 to 40%. The tidal volume is going to increase. Now, granted, this is not all at once. This is during the course, the duration of the pregnancy. But tidal volume will increase by, 30 to 50%. When that happens, it's going to increase your minute volume by as much as half. It's going to drop your partial pressure CO2 by about 5 milliliters of mercury. It's going to decrease your blood bicarbonate levels. You're going to have a slight increase in your plasma pH. This is why women tend to be just a little bit acidotic. Pregnant women, that is. It's going to affect your acid-base balance. Really affects a whole lot in the body. The minute volume is going to be affected by that slight increase in respiratory rate, so it's going to raise to about 10 liters per minute. Now, the cardiovascular system, a whole lot of changes here, okay? It significantly impacts the circulatory system. Your blood volume is going to go up by 30 to 50% or maybe even more. So it depends on the patient size. Bigger people tend to have more blood volume anyways. If they're carrying multiples, 2 babies require more blood than 1 baby does. So, it just depends on how many they have. How many times they've been pregnant, how many times they've delivered. All of that kind of affects how much blood volume goes up as well. So this volume goes up because we've got to meet those metabolic needs of the developing fetus. But we also have to still adequately perfuse all the maternal organs. So, it's got a lot more stuff that it has to do here. This is also going to help compensate for any blood loss during delivery. Remember, a woman can lose as much as 500 milliliters of blood during a vaginal birth and up to 1,000 in a C-section. Right? The number of red blood cells are going to increase as the blood volume increases by up to about 1/3. All right? This is needed to, transport more oxygen, right? But this also means that the woman's going to need more iron, which is typically found in your prenatal vitamins. The fetus will actually take some of the maternal iron stores, which can result in anemia if the mom doesn't take the prenatal vitamins and increase that iron intake. And we know iron is necessary for hemoglobin to bind with the oxygen, right? White blood cells go up as well. The clotting factors will go up, but your fibrinolytic factors go down. Right, so this means that they are more at risk for some bleeding, but they're also more at risk for some clots. Right, the size of the heart itself will increase with blood volume. So, 10-15%. Now, a normal healthy person can handle it, no big deal, but this is why some women will develop gestational heart failure. If they are already at risk or have some underlying issues, they can just suddenly develop this heart failure that's induced by the pregnancy. Some women will need a heart transplant. Some women will be resolved once they deliver. All right. But this cardiac output is going to increase by 30 to 50% more than a non-pregnant state because of the increased blood volume, increased size of the heart. It's going to reach maximum capacity by about 22 weeks, and from there until term, it's going to stay pretty level. All right. As the uterus is enlarging, the diaphragm elevates, and everything else is kind of shifting to make room. It will literally cause the apex of the heart to shift forward, upwards, and to the left a little bit. So it's literally moving your heart. Now this will change the intensity, the lub-dub that we listen, we hear when we listen to lung sounds. The S1 sound will increase, but the S2 sound will sound pretty much normal, so it'll be a little different sounding than a normal lub-dub. This increased cardiac output could also cause kind of a benign systolic flow murmur that you may hear. Not common, but you may hear it. Right? The heart rate will increase by an average 15 to 20 beats per minute by the full term. You may also see some EKG changes, ectopic beats, SVT. Now, slight SVT in pregnancy is not super concerning in and of itself. They typically will not be symptomatic from that. You may have a slight left axis deviation because it's literally shifted. And you may see a little bit of low voltage QRS, T wave inversions, or occasional Q waves in lead 2 as well. Right? Their body positioning also will have some changes that occur with the cardiovascular system. We know that if they lie supine in that third trimester, it can cause compression of the inferior vena cava, which reduces the venous return to the heart. Right? This can also be caused by pressure of the fetus on the common iliac vein. And if that pressure is not relieved, cardiac output's decreased, and then we'll show signs, hypotension, lightheadedness, that kind of stuff. The systolic pressure usually will decrease until about week 24, and then it will start to go up from week 24 until birth, but it should not go up substantially. If you see anything above systolic 140 in a pregnant woman, be concerned and pay attention to it. Alright, the venous pressure will increase progressively in the lower extremities, especially late in pregnancy. And what this will do is it'll help slow venous return. It'll cause pooling, edema in the lower legs, varicose veins, hemorrhoids. And if they're bedridden or lay down a lot, they may develop DVTs, which can lead to a pulmonary embolism or other clotting, related issues. The birthing position itself. The lithotomy, and I'm probably butchering that name, but that's what we're going with, is the standard position. That's where they're supine with their knees apart or feet in stirrups. This actually is going to increase the workload on the heart. So, the workload already increases in gestation and labor, and if they have some kind of underlying heart issues or compromise, it can cause ventricular failure, pulmonary edema, CHF, even pain and pressure of labor can even cause straight up cardiac arrest. So a lot of things that can occur during this. Now, luckily, it doesn't happen super often. GI system, alright, so pressure on that rectum can lead to constipation. The slowed GI motility, so like the peristalsis that keeps everything moving along, slows down as well. So this can lead to heartburn, burping, more gas in general. It can lead to more constipation because things have longer for the water to absorb out of the large intestine. You have a slower emptying of the stomach because it's kind of got pressure from below, right? So that can lead to some nausea and some vomiting. Your urinary system, and kidneys is misspelled, but the kidneys actually increase in size and volume as a direct correlation to the increase in blood volume because they filter out all the blood, right? Your ureters are going to increase in diameter because they're pumping out more urine. You have an increase in urinary frequency and urgency, and literally because the fetus is sitting on the bladder, especially once it gets like the last half the second, the third trimester. So you have an increased sensation of urgency and frequency there as well. Musculoskeletal. This one cracks me up. Relaxin. The hormone is relaxin. It just like somebody was like, yeah, what are we going to do? What does it do? Relax the muscles? All right, yeah, relaxin's good. It is going to increase your joint laxicity. So basically it makes them loosey-goosey. All right, it's going to increase the lordosis, which is that abnormal spinal curvature. You ever notice like a really super pregnant woman, like she kind of waddles and like she's probably going to hold her hands on her back and belly's poking out and she's got that curve back there? It's because of this hormone that's causing her bones to separate. You'll have the pubic symphyseal will relax. That's where the pelvis meets. It will start opening up a little bit and allow for separation for that fetus to drop down during the actual birthing process. This kind of plays in sometimes to some of the trauma related incidents because you're a little more prone to like sprained muscles and things of that nature. Alright, so around the 4th week of pregnancy, the placenta starts to develop. Can you list the functions? Give you a hint, it's a lot of them. Alright, so some of them serves as an early liver. It's going to synthesize your glycogen, your cholesterol, fatty acids, produce your antibodies, do your gas exchange, nutrients, waste, heat, your HCG, your human growth hormone. All kinds of really cool stuff that it does. So let's talk about what happens during those first 4 weeks of pregnancy. So 1 week after conception, the egg now is a blastocyte. Hopefully it's going to migrate to the endometrial wall and become implanted about a week after conception. Right? And you've got these enzymes that are going to dissolve this endometrial tissue that's going to provide nourishment for the development of this blastocyte. And with this, the implantation may result in a little bit of vaginal bleeding, like a spotty vaginal bleeding. Some women may mistake this for a light menstrual cycle, just depends. All right. Implantation, when that occurs, will actually trigger the development of your placental tissues to start developing and stimulates the release of your human I can't even say that word. It's HCG, your human growth hormone is what it is. But that signals kind of pregnancy has started. And until the placenta is fully developed, the corpus luteum, which is left over from where the egg kind of like burst out of the ovary, will actually produce the hormones to support the pregnancy until that point. Now, about 2 weeks after conception, the blastocyte is now an embryonic disc, and the placenta starts to tap into the external layer of the blastocyte. Right, so you've got, this little area, and this is where the maternal blood is. All right, and this connection will actually help allow the embryo to draw on maternal circulation. So that's where the umbilical cord eventually will be. So at this point, totally qualify as a parasite. All right, 3 weeks after the conception, the blastocyte is now officially an embryo, and we're starting to have body systems form. We've got a start of a nervous system, we've got the start of a cardiovascular system, we've got the spine, we've got a little bits of the skeletal anatomy, we've got kind of an S-shaped tube-like heart that starts to beat, kind of quiver back and forth. You've got blood cells that are circulating in the 4th week. All right, your placenta is developing and starts to serve as that liver, metabolizing those fatty acids, producing antibodies and gas exchange and all those fun things that we just talked about that the placenta does. So really cool stuff there. All right, so cultural considerations. The United States is really probably the most, if not one of, it's definitely in the top culturally diverse nations in the world, right? So this is a big consideration. If somebody's culture is different from yours, we really want to be considerate of them. It may not be something that we see as normal, but it may be normal for them. They have different value systems, and these may affect their pregnancies, okay? Some may have certain plans for childbirth process. They may want water births. They may want silence. There's a lot of different things that can happen. Some cultures may not permit a male healthcare provider to assess or examine a pregnant patient. Every culture is going to view pregnancy and delivery just a little bit differently. Our responsibility is to provide care and to provide transport, but also to respect the cultural differences and honor any request as we can from those patients.